Dear colleagues, in the next few minutes, I will try to illustrate the eye tracing machine and how to use it in the premium lens and refractive dilemma practices to understand and measure better quality of vision. I have no financial interest. What is the eye tracing machine? Eye tracing machine is a machine that measures the wavefront aberrations using the ray tracing technology. It is also a corneal topographer, which is a Placido disc topographer. It's an autorefractor. It gives a very accurate refraction. It's an autokeratometer, pupillometer, which measures the pupil in the scotopic and the photopic conditions. And it has the character of the DLI, which is the abbreviation of dysfunction lens index page for premium candidates and patient education. It's very important to check the toric accuracy after surgery of the toric IOLs or the toric ICLs without dilatation of the pupil. It is the only device that will scan through an IOL inside the eye. So the value of this ray tracing aberrometer, it helps in understanding the quality of vision through better optical alignment measurement, especially the angle kappa and angle alpha, and its effect on treatment choices and results, separating the optical components of the eye to have better quality of vision assessment, whether it is the problem from the lens or from the cornea, premium IOL planning, customizing the cataract surgery for better results, whether the candidates are suitable for trifocal IOLs or advanced monofocal or only monofocal, especially after refractive surgery, and post-operative problem solving regarding the toric axis checking, tilted lens assessment centration, and many other values. So let's take every point separately to discuss together. What is the value of this ray tracing machine in the optical aligned measurement and its effects on treatment choices and results? This is the first case as a candidate, as you see the cursor here. This is a good alignment with low angle alpha and good candidate for multifocal IOLs. As you see, the visual axis is coincides with the optical axis inside the center of the pupil, which gives an angle alpha even in green color, which is more than enough that it is okay. With higher, the aberration is less than 0.062 microns, in spite of the high refraction of the patient of -7 diopters and half astigmatism. But in the second case, where the visual axis is not aligned on the optical axis, this is an extremely high angle alpha with poor candidate for multifocal IOL. But honestly, it had been thoroughly investigated, showing that the angle alpha and angle kappa are not so important in the choice of the trifocal or the multifocal IOLs, but they are very important in treatment of patients for refractive corneal surgery. In hyperopes, we have to measure this angle alpha or angle kappa to correlate it or to compensate it on the machine in order to have a better quality of vision. And the third case is an in-between case showing in a yellow color that the angle alpha is a mid-distance in between. It coincides with the visual axis, the optical axis, and the central part of the cornea relatively. So this patient can do trifocal IOL, and you have to take care in the refractive surgery. This is the picture that we see for the eye tracing machine, showing the total eye letter. This is what the patient actually sees. And it is divided into two components. The corneal component, the letter E in the cornea here is clear. And again, to subtract the corneal from the total component, it will give you the internal component, which is referred to the dysfunction lens index, and it is referred to the only optical organ which is present inside the eye behind the cornea responsible for this E, which is the human lens. So the internal aberrations or the internal harder total aberrations reflecting the dysfunction lens index, and the cornea letter reflecting the cornea, and this is the total appearance. This patient sees what this E in this pattern because the cornea is okay and the lens is also okay. This is this shows when the IOL is a little bit decentered from the visual and optical axis, and that may cause high order aberrations, and the patient is not happy. Regarding the second point, which had been paved by the previous slide to separate the optical components of the eye, lead to quality of vision assessment, which is the dysfunctional lens index. As you see here, again in details, in the previous picture, we saw the total E. This total I aberrations is divided into all the root mean square total high order aberrations here. Again, it is divided into the corneal and subtracted from the total to give the internal. So here it shows that the astigmatism here is mainly due to the corneal aberrations and not due to any lenticular aberrations. So this enables the assessment of the quality of vision for the components of the eye, knowing how they combine for overall vision. This is the E what the patient is seeing, showing internal high order aberrations, which is very high, and very low dysfunctional lens index, which means that this patient has significant cataracts. The low dysfunctional lens index number means reduced function of the lens. Green on color scale is normal. Good and warmer colors equate to reduced function. And the letter E reflects the quality of vision from internal optics, which is the lens. So when you show this picture to the patient, he says, yes, I see this E letter exactly. I cannot see, yes, I see the E, but I cannot actually recognize it due to the blurring of vision. So this is a way of educational to the patient. And this patient, we tell him with this refraction, you are not a good candidate for refractive surgery because the problem is not in the cornea, because the corneal high order aberrations is okay, and this is the corneal part, but the main problem is in the lens. So this leads to low dysfunction lens index, which means that the problem in the lens. These candidates, if you do LASIK for them, definitely they will not be happy because we didn't treat the main problem, which is the lenticular opacity or the dysfunction lens index. Even this opacity map correlates to the slit lamp. This blue color and white color shows the opacity, and if you compare to the slit lamp, you see the cortical opacities at the periphery, which means that these colors are reflecting the opacity in the human lens. This patient has an early posterior subcapsular cataract with patient complaints that he is seeing blurring vision and in spite of having myopia, but the cornea is okay with a very good topography and case, but the main problem is in the internal high order aberrations, which is high 3.3 and low dysfunction lens and due to the lenticular opacity, as you see here. When this patient is doing cataract, he benefits more than doing any LASIK surgery. This is an example of the patient that before we did him the eye Tracy, showing this is the blurring of vision, and this is the dysfunction lens index, which is very low before the surgery, that had improved markedly after day one, and better in spite of having the same refraction before and after surgery, but there is a big difference in the lenticular opacity before and after surgery, and the patient had improvement of vision due to the cataract that had been done with better quality of vision. And again, this map is very important because it shows the MTF, or the model transfer function. And to simplify this map, if this yellow line passes inside the red box, this means that the MTF, or the quality of vision, is bad. But if it is like you see here, the total high order aberration modulation transfer function, showing that the yellow color is in the middle of the red box. When it moves to the periphery of the red box or outside the red box, this means that the MTF is starting to improve. So if you have before surgery, the MTF is inside the red box and it is total, see whether it is from the cornea more or from the lens more, and this definitely improves after the surgery. So the unexpected cataract for cases seeking refractive surgery. This patient is asking for refractive surgery with this refraction, but his cornea is okay, and again his lens is opaque, and with the best corrected visual acuity reached 0.6, and one day after surgery, there is improvement of the dysfunctional lens index and improvement again of the visual acuity and better refraction. So here the problem again was in the lens and not in the cornea. So to plan for the premium IOL, whether to do toric or not toric or multifocal IOLs, this helps, as we all know that the K readings are not the same in all machines. The manual keratotomy measures the center 3.2 millimeter, where it finds the steepest point and takes it an annulus location to the point at 90 degrees. This is the regular manual K reading machines. And the autokeratometer, which is present in the autorefractometer, it simulates the keratometer but with more points at various sizes depending on the instrument, whether in the lens star at 2.5 millimeter or IOL master is 2.35 millimeter. And on the other hand, the simulated keratometers, which is in most of the topographies, it's only 4 points that we measure the K through it. But the refracted keratometry, which calculates the average steep and flat power and access from all topographic data within 3 millimeter circle, which is not only 2.4, 2.5 millimeter, like the IOL master and the lens star, using the Snell's law may not be orthogonal, and this is only available in the eye traces. Adding to it, the Zernike analysis to this topography machine will give the best wavefront keratometer, which sometimes may differ the sim K from the wavefront K, and it is only available in the eye tracy within 4 millimeter. The larger the diameter, the better the results. So sometimes you have the sim K depending on K1 and K2, which is different from the wavefront K, which depends on the Zernike analysis, and it is more accurate, and we have to depend on the wavefront K readings and not the sim K readings to have the accurate astigmatic power. Again, Osher, because there is a colored camera in this machine, had invented a way to see where are the blood vessels and at which angle, and to put points at these blood vessels which are sure 100% where are they and the angle of these blood vessels. And even without marking, you can know from these 3 points where is the actual positioning of the toric IOL. So this picture, you can take it with you in the OR, and depending on these blood vessels and this diagram, you can put the toric IOL without marking them. And again, maybe the most important value of this eye tracer is to solve the post-operative problem when the patients are not satisfied with their vision, especially in the toric IOLs and the toric ICLs. It eliminates the time-consuming dilatation and inconvenience to the patient. There is no need to dilate the patient to check the toricity of the IOL or the ICL, and know in minutes if an enhancement is necessary or not, and see a predicted refractive result to better determine next steps and to which side to rotate the IOL or the ICL. To be on practice, this is the planned toric IOL that should be on 89 degree, and this is the actual target axis that to put on 88 degrees. So there is a difference of 1 degree rotation, and this one current corneal power astigmatism is measured, and the toric lens power is measured, and this 1 degree of rotation will not change the cylinder, as the trace refraction now is very similar or near to the predicted post-operative rotation refraction. So there is no need to rotate this IOL, and this IOL is well aligned and the patient is happy. But if the toric lens axis, for example, on 98 degrees and the target axis is on 90 degrees, or the actual 90 degrees, so there's a difference of 8 degrees rotation. But even in these cases, the Tracy will tell you there is no need to change, because there will not be much change in the power of the or the diopter of the astigmatism, so there is no need to change it from its place. But if the angle is increasing up to, for example, 25 degrees, here is the planned axis 110, but the actual axis is the planned axis is 110, and the actual target axis is 85. This big difference resulted in 3.72 diopter change in the cylinder power. So you have now the refraction is +1 with -3 diopters, and the actual refraction should be -20.275 -1 to give better results. And this is the current corneal power axis and the toric lens power. So you have to change the IOL 25 degrees anti-clockwise to correct this high degree of astigmatism that had been resulted from the rotation. This is my 2 days ago case that I did Toric ICL on the 28th of December, 2 days ago. And here the patient, the target axis was 97 and the toric axis 98. This young lady, I did her toric ICL, showing that 3 degrees of rotation will not change the cylinder power, and this is the actual refraction of the patient and aimed refraction, so there is no need to change it, and the patient is satisfied with the autorefractometer. This is the ICL, and the patient is seeing 1.2 post-operative day 1. So it is very important to assess the toric stability in the IOLs and in the ICLs. You have to always respect the patient's complaint. This young medical student, type A personality, did LASIK by one of our colleagues. He's not satisfied with his right eye, but his vision is 0.8 in the right eye and 1 in the left eye, with nearly the same refraction. And of course, when he is going to any other doctor, he says your refraction is okay, there is nothing to complain. But the Tracy shows there is a difference between what is the patient seeing with the left eye, with the E better definitely than the right eye. And the problem here is in the corneal astigmatism or the corneal wavefront. So here the student, he put his fingers on the ears and he said, yes, this is what I'm seeing and this is what I'm complaining. So this is the first point to stress on, that you illustrate to the patient that the problem is here, and he is convinced because this is what he actually is seeing. So I asked him to analyze more where is the problem, and as you see here, the corneal astigmatism in the left eye is definitely much lower than the astigmatism in the right eye, and this is a high order aberration which is apparent more in the right eye. But at this stage, after 1 month, and I asked him to wait to see what's going on after at least 3 months and to see what's the results. 4 weeks after LASIK, this is the picture of the same guy. 6 weeks later, there is a starting of the maybe better appearance of the E than before the 4 weeks. So the dryness and in spite of having the same refraction nearly of the patient after 4 or 6 weeks, but I'm asking the patient to wait more and more before doing any topo-guided correction. Another very important point is in the intercorneal ring segments implantation in patients with keratoconus, like this patient who had this appearance with 0.8 visual acuity and high astigmatism before the ICRs, and much better E after the insertion of the ICRs, and the patient definitely has better quality of vision, as these rings regulate the irregular cornea in cases of keratoconus. And to have more details, seeing the astigmatism before and after and the refraction of these patients. Another patient, again with best corrected visual acuity with -3.5 dot of astigmatism, had been corrected up to 1.2 unaided with depending on the refraction of the Tracy, which helps in the nomogram of the intercorneal ring segments, and showing how this topography became more regularized after insertion of the rings with the help of the Tracy and with more convincing to the patient. This is a 28-year-old doctor that was diagnosed as bilateral keratoconus in April 2019. I did her DALK in her right eye and cross-linking in her left eye. Her uncorrected visual acuity after the DALK was 0.9 1 year post-operatively. I removed the sutures on September 2020, and the patient felt drop of vision to 0.3. And again, this point, just to know, from my mistake, there is no need to remove the suture as long as the patient is satisfied. Nothing will happen from remove the suture, even if you find it on the topography or the pentacam flat. Preferable to keep it as it is because it is unexpected result, or definitely the patient may feel drop of vision after removal of the suture due to the change of the topography of the cornea. So I took the decision after removing the suture with 6 months to do intracorneal ring segments for this patient. Here is the eye trace of the patient before the surgery, showing how the astigmatism is very high on the cornea, and the best correct visual acuity was 0.3, and after the surgery the patient had visual acuity of 1 with more correction of astigmatism and less high order aberrations and better refraction. So the patient was very satisfied, and here is the picture of the patient with the DALC and the rings inside the DALC, and this is one of the very good ways to treat astigmatism after keratoplasty. More solving of problems of after with the eye trace, even with the tilt of the intraocular lens, using this rulers to see whether the IOL is centered or not, and whether the IOL is tilted or not. Having this green line means it's in the center, and this blue line means it's shifted to one side, and the red line means it's shifted to the other side. Yes, it may be, it's a rough way to know the tilting of the IOL with this way of the tracing, but definitely with more advancement of science in this point, we can diagnose the tilting of the IOL, whether it is upside down or right to left, and this tilt is very important in cases of multifocal IOLs. So the benefits of eye trace in general in premium cataract procedure includes it's an easy and rapid test to show the doctor-patient vision problems, how the eye is looking like. Eye trace locates the vision problem, whether it is in the cornea or the lens. It helps to select the best intraocular lens to use and plan surgery for it. And it verifies the results and checks the positions of the lens. It even solved the problem of post-operative decentration or tilt or toric check. And all these factors maximize the quality of vision. How it helped me? It helped me to have a very good confidence from the surgeon and the patient to have more toric and more multifocal IOLs that offered looking at the scans before they see the patient, and the doctor will know if the patient is a good candidate or not for these toric IOLs. And the patients can see how an astigmatic lens will help them to see better, and how this toric IOL will correct the quality of vision by decreasing the astigmatism. And this toric check helps the surgeons to nail this astigmatism after the surgery, and it is the only device that will perform an auto refraction on a multifocal IOL. And at the end, I would like to thank you all for listening to this lecture. Thank you so much.